Indu Narayanan. She is a consultant oculoplastic surgeon at Comtrust Hospital. She will be addressing Twitchy lids. What to do?
Good morning, everyone. Thank you, Dr. Shabin, for giving me this opportunity. So, this is not a very uncommon condition, twitchy lids, and often it is very debilitating for the patient. So, let me begin with the anatomy, very relevant anatomy. What do you think are the muscles that are required when a patient closes his eye? So, there is the first and the foremost, it's the orbicularis, which comes into action. Contraction of the orbicularis. And all of us know that there are two parts of orbicularis. It's the palpebral and the orbital part. So, the orbital part, can I have the pointer please? So, this is the orbital part which covers the beyond the orbital rim, and this is the palpebral part which is divided into pretarsal and the preseptal. So the palpebral part, it helps in the normal closure, and the orbital part, it helps in the forceful closure of the lid. And it's not just the orbicularis which acts on closing, it's also the levator. The relaxation of the levator causes the closure of the eyelids. So this is a very pretty common condition. This is called as the orbicularis myocymia. Here you can see that there is transient flickering of the lower eyelid, and it's usually commonly seen in the young individuals. There is spasm of the single muscle fiber or a bundle of muscle fibers. So the myocymia, what is the main cause for myocymia? It's often the stress, lack of sleep, and excessive intake of caffeine or the alcohol, tea. So how do we counsel the patient? It's a benign condition. It's not, there is nothing to worry. It's usually resolves by self, and you can ask the patient to have good sleep and reduce the tea intake or caffeine intake, and often the lubricates helps to a minimum. Is botulinum toxin indicated in such cases? Only when it is very severe, I mean in chronic conditions where it is more than 3 months or so, if it persists. So next, video please. Yes, this is a 65-year-old lady. It's called as the benign essential blepharospasm. So what is it? It's involuntary, repetitive, progressive muscular orbicularis contraction occurring. It's mainly common in females. More than that means more than 50 years. So this often starts with excessive blinking or photosensitivity. It often starts in one eye, but finally it ends as a bilateral condition. This I was actually, when I was taking the videograph of the patient, I was not able to get the spasm. I couldn't, because the patient was deeply concentrating, and on concentration it disappears. Okay, so this disappears in concentration as well as in sleep. And the diagnosis, it's always clinical. It doesn't require any imaging here. So what's the management? The lubricants or the tinted glasses and some of the medications such as antidepressives or anxiolytics, they are of not much use. And this is what happened to the patient. Play the video. Yeah. So what is the wonder drug? All of us know it is the botulinum toxin. Botulinum toxin type A, it's an exotoxin, and it acts by the mechanism of chemodenervation. It acts as the neuromuscular junction, and it blocks the release of acetylcholine. So it's commonly available in the dry powder form, and it's constituted with preservative-free normal saline. And the concentration of botulinum toxin that we inject in functional conditions, it is 2.5 international units per 0.1 ml. So this botulinum toxin is usually available in 50 units or 100 units. But the final concentration that we make is 2.5 international unit for the functional indications. So these are the common sites of injection used for blepharospasm. You can see it is the pretarsal orbicularis, targeting the pretarsal orbicularis, and also one point which is 1 centimeter lateral to the lateral canthi, and oftenly the corrugator superciliaris. Sometimes even the procedures may also be involved. We need to give at that point. So what are the sites which are avoided? This one, that is the central part of the upper lid, because it causes ptosis. It may involve levator and it can cause ptosis. And the lower part of the, medial part of the lower lid, because it causes the ectropion. So the action of Botox, it usually starts within 3 to 5 days and peaks within like 3 weeks. It lasts only for 3 to 4 months. It is due to regeneration of the new axons. So there are very few contraindications for botulinum toxin. It's pregnancy, lactation, and other neuromuscular disorders. So this is the next condition. Play the video, please. So this is hemifacial spasm. It's a unilateral, you can see that unilateral involuntary contraction of the muscles which are supplied by the seventh nerve, and it's common in the middle aged. The cause here is that it is the vascular compression which causes compression over the axon of the seventh nerve when it comes out of the brain stem. And sometimes very infrequent, it's 1%, less than 1%, it is due to posterior fossa tumors. So a neuroimaging MRI with MR angiogram is very essential, unlike the other one, blepharospasm. And the definitive treatment is microvascular decompression procedures. So, and hemifacial spasm, the sites are almost the same regarding the upper part of the face, but when it comes to the lower part, we target at the zygomaticus major, ask the patient to clench the teeth, and then also the depressor anguli oris. Sometimes the mentalis may also be injection is required to that point. So what are the what do we give instruction to the patient? Do not rub the face or do not lie down in the very 1 to 4 hours, because it can cause a gravitation and cause the side effects. Always avoid heavy exercise and alcohol following a day. So here you can see that this lady, there is no much spasm, but you can see once she closed the lid, she is unable to open it up. And it is with her mechanically she has to lift up the lid. What is this condition? It is the apraxia of lid opening. It's basically the difficulty in initiating the lid opening after closure. This is often very difficult to treat comparatively rather than the other two conditions. And in severe cases of apraxia, initial treatment will be the botulinum toxin only, but in some cases which is very refractive, you may have even to go in for a surgical myectomy. So in myectomy, here the surgeon is putting a blepharoplasty incision, and the skin with the orbicularis is excised. Here mainly the pretarsal and the preseptal, that is the palpebral part of the orbicularis, is removed. Not always here you can see that the pretarsal and the preseptal part, that is the palpebral part of the orbicularis, is removed, and not always the orbital part is only removed in very certain conditions. So just to summarize this, blepharoplasty incision, then the skin along with the orbicularis is taken, that is the palpebral part. So here you can see that the pretarsal orbicularis, it is separated from the tarsal plate and the skin, and finally the preseptal part is also removed. So with that I conclude, and thank you.
Thank you, Indu. Thank you so much for that extensive discussion.